Oxygen is probably the most important thing you need. You can go weeks without food, you can go maybe days without water. However, within 10 to 15 minutes of being deprived of oxygen, your brain dies. But have you ever wondered, why do I need this oxygen to survive? My name is Abdul-Rahman Bassam, and I'm here to tell you why. You see, oxygen is the most abundant element on planet Earth. It makes up 23% of the Earth's atmosphere and about 89% of the Earth's water. All aerobic organisms need oxygen to break down carbohydrates and food molecules into energy in the form of ATP, which is used to fuel every single action that our body performs, whether it was talking, thinking, listening to a seminar, presenting one, or literally anything. The lungs are the ventilators that supply our body with the oxygen, and the blood is the truck that carries that oxygen to the tissues. Whenever there is a defect within any of them, hypoxia occurs, which impairs body's functions and may lead to body organs failure or even death. The list of the most important categories of diseases which can cause such condition can never exclude a very interesting one, which is called the group of pulmonary vascular diseases. And that's why we chose them to be the topic of our seminar today. Pulmonary vascular diseases are disorders affecting the blood flow through the pulmonary vasculature or fluid flow from the pulmonary vasculature. They are not usually fatal by themselves, but their complications could be fatal. In this map, you can see the hospital admission rate for pulmonary vascular diseases, which in some countries like Netherlands, Sweden, or Romania, it may exceed 50 cases per each 100,000 admissions. That's a fairly common rate. In order to understand pulmonary vascular diseases, we first need to understand the normal anatomy and physiology of the lungs. As you know, the lungs represent primary respiratory organs in the body. Anatomically, they are bilateral conical spongy structures situated on either side of the mediastinum within the chest cavity, covered with the visceral pleura. They are separated from each other by the heart, great vessels, and the other organs of the central mediastinum. On the way to the lungs, the first parts that the air goes through are the mouth and the nose cavities, and then it makes its way to the pharynx, larynx, trachea, which splits upon reaching the lungs into two primary bronchi, and these two primary bronchi inside the lungs split into several secondary bronchi and tertiary bronchi, which end up in bronchioles and terminal bronchioles. So, where does gas exchange occur? At the end of each bronchiole, there is a special area that leads into a clumps of tiny air sacs called alveoli. There are about 600 million alveoli in your lung, and if you stretch them out, they would cover an entire tennis court. These tiny balloon-shaped air sacs at the very end of the respiratory tree are arranged in clusters throughout the lungs. They allow oxygen and carbon dioxide to move in between the lungs and the bloodstream, more specifically between the air sacs of the alveoli and the capillaries. Since we know now that the pulmonary vascular diseases affect the blood flow within the pulmonary vasculature, we first need to understand what is the pulmonary vasculature in the first place. The lungs receive dual blood supply. Their main supply is from the pulmonary circulation directly, and their partial supply is from the bronchial arteries from the systemic circulation. And to explain what we mean by pulmonary and systemic circulation, we need to take a look at the lungs' connection with the heart. You see, the heart collects the deoxygenated blood returning from the great veins through the right atrium, and then the right ventricle pumps it to the lungs through the pulmonary arteries. After this deoxygenated blood goes through the pulmonary capillaries and gas exchange occurs with the alveoli and become oxygenated, it's collected back by the pulmonary veins to the heart. And this circulation that oxygenates the deoxygenated blood and brings it back to the heart is called the pulmonary circulation. The left half of the heart then receives the oxygenated blood and pumps it through the systemic circulation. Since we have covered everything we need to know about pulmonary vasculature, my colleagues will take you on a journey through the bunch of the most important diseases affecting this vasculature.
A pulmonary embolism is a blood clot in the arteries of the lung. It's one of the most dangerous type of venous thromboembolism, which is a general term for when a blood clot forms in vein. My name is Alaa Mohanad. Let me take you on a short journey to learn more about this topic. 1 in 10 patients dies due to thromboembolism every year, and at least 1 in 5 patients will have recurrence within 5 years. About 10,000 patients die each year due to pulmonary embolism, and 2 to 4 per 1,000 cases incidence rate per hospitalized patient. So what's embolism? Embolism is the process of formation of an embolus. What do we mean by embolus? Embolus is a detached intravascular solid, liquid, and gaseous mass that is carried by blood to a site distant from its point of origin. About 99% of emboli are formed by thrombus. When that happens, they call the thromboemboli. For that reason, we should be particularly interested in discussing thromboembolism. So, how does a thrombus form? In the first step of a clot formation, platelets are recruited to the site of vessel's injury by newly exposed molecules of vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of a platelet to a collagen via a specific receptor on the platelet's membrane. The resulting change of shape of platelets from resting state into dendritic form indicate platelet activation. The activated platelets in turn release a prothrombin molecule such as adenosine diphosphate by binding to its receptor. Adenosine diphosphate induces aggregation and recruits further platelet to the site. Thromboxane A2 is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. The clot grows rapidly. Activated platelet also triggered the coagulation cascade, and thus the formation of the thrombin, which in turn stimulated platelet activation even further. Additionally, thrombin induced formation of fibrin for the mesh stabilizing the clot. Sometimes the thrombolytic system fails to break down the clot, which lead to thrombosis and possibly embolism. So thrombus is actually made of RBC, platelet, and fibrin. In other words, it's a collection of RBCs clumped together with the platelet and fibrin. Pulmonary embolism occurs when deep venous thrombus detach and embolize to the pulmonary circulation. More than 95% of all pulmonary emboli are arising from a thrombus of large deep veins of leg, mostly popliteal vein and larger veins above it. So, how it can affect the lung during respiration? This is an alveolus, pulmonary artery in blue and pulmonary vein in red. Ventilation is the air moving in and out of the lung, while perfusion is a blood flow to and out of the lung. When an embolus is large, it can cause two main things. Firstly, it can cause ventilation-perfusion mismatch. So, embolus causes abnormal gas exchange. Secondly, it can cause an inflammation. Inflammation results in a lot of cytokines, thromboxane A2, and serotonin release, which lead to a bronchoconstriction. Bronchoconstriction leads to hypoxia, which will stimulate hyperventilation, forcing the patient to breathe rapidly. And hypercapnia occurs due to decreased carbon dioxide level in the blood. This alerts the dynamic equilibrium of carbon dioxide in the circulatory system. Circulating hydrogen ion and bicarbonate are shifted through the carbonic acid intermediate to make more carbon dioxide via the enzyme of carbonic anhydrase, according to the following reaction. This causes decrease in circulating hydrogen ion concentration and increase the pH. It means an alkalosis. Alkalosis can cause this constriction of the small blood vessels that supply the brain. Reduced blood supply to the brain can cause a variety of symptoms, including lightheadedness, feeling of faintness, and a severe hyperventilation can cause a transient loss of consciousness. The pathophysiologic consequences of pulmonary thromboembolism depend largely on the size of the embolus. Small pulmonary embolism may not cause any symptoms. A large embolism will reduce blood flow to one or both of the lungs. This can cause inflammation of the tissue that covering the lungs and chest wall in a condition called pleurisy. And this can cause a sharp chest pain, trouble breathing, and rapid heartbeat. If a large pulmonary embolism gets trapped in the main artery that leaves the right side of the heart, known as the main pulmonary artery, no blood can leave the heart at all due to the obstruction, and this will almost inevitably result in sudden death. This is known as a massive pulmonary embolism. Here we can see a large saddle embolus from the femoral vein lying astride the main left and right pulmonary arteries. And this picture shows a gross pathological appearance of pulmonary embolism. Pulmonary infarct typically are hemorrhagic and appear as a raised, red-blue area of coagulative necrosis in early stages. Individuals that increase body risk of pulmonary embolism include old patients, those with pneumonia, those who are undergoing surgery or long hospitalized state, people who have a major features trauma, people who are immobile for a long period. Other medical conditions can cause a risk factor like genetic disease, sickle cell disease, and chronic obstructive pulmonary disease. Patient presented with a chest pain, shortness of breath, heart palpitation, coughing up blood, fainting, and in severe cases, sign of shock and low blood pressure. So, how do you know it's a pulmonary embolism? Well, investigation can be performed by using an X-ray, CT pulmonary angiogram, ventilation perfusion scan, and D-dimer blood test. Now my colleague will continue.
Welcome to Pulmonary Hypertension with me, Isra Mohammed. The pulmonary circulation normally is one of flow resistance, and pulmonary blood pressures are only about 1/8 of systemic pressures. The normal pulmonary artery pressure is about 25/10 mm mercury, with mean arterial pressure of 14 ± 3 mm mercury. Every year on May 5, pulmonary hypertension organizations around the world participate in activities to raise awareness of this frequently misdiagnosed disease and celebrate the lives of people living with pulmonary hypertension. As measured by right heart catheterization, the pulmonary hypertension refers to increased blood pressure in pulmonary circulation as a mean pulmonary arterial pressure of greater than or equal to 25 mm mercury at rest. Pulmonary hypertension has diverse causes. It is most frequently associated with structural cardiopulmonary conditions that increase pulmonary blood flow and vascular resistance. Based on shared features, the World Health Organization has classified pulmonary hypertension according to pathological, pathophysiological, and therapeutic characteristics into the following 5 groups: pulmonary arterial hypertension, pulmonary hypertension due to left-sided heart disease, pulmonary hypertension due to lung disease and or hypoxia, chronic thromboembolic pulmonary hypertension, and pulmonary hypertension with unclear or multifactorial mechanisms. Starting with the more common causes, it is most commonly developing as a result of left heart disease. Here the pulmonary blood vessels are normal and undamaged, but the left side of the heart is unable to pump efficiently. For example, because of heart failure or valvular dysfunction. This causes backup of blood in pulmonary veins and capillary beds that is eventually transmitted to the arterial side of the pulmonary vasculature, leading to hypertension. Raised back pressure may trigger secondary vasoconstriction, and this leads to increased right heart strain. Another cause of pulmonary hypertension is chronic lung disease, which typically causes hypoxic vasoconstriction. That's when an area in the lung is unable to deliver oxygen to the blood. To adapt to this, the pulmonary arterioles in that area start to constrict, and this effectively shuttles the blood away from these damaged areas in the lung and towards healthy lung tissue. But in chronic lung disease, such as COPD or interstitial lung disease, there is a prolonged alveolar hypoxia across wide portion of the pulmonary vascular bed. These diseases obliterate alveolar capillaries, increasing pulmonary resistance to blood flow and make it harder for the right ventricle to pump out blood. So it has to generate increased pressure, and that results in pulmonary hypertension. Another cause is chronic thromboembolic pulmonary hypertension. When there is recurrent blood clots in pulmonary vasculature, the clot can block the pulmonary vessel, and that may cause pulmonary hypertension by reducing the functional cross-sectional area of the pulmonary vascular bed. One type is pulmonary arterial hypertension, when there is elevated pressure in the pulmonary arterioles, but the pressure in the capillaries and pulmonary veins is still normal. Results from chronic remodeling of the small pulmonary arteries leading to progressive vascular obstruction. It can be idiopathic, inherited, drug and toxin associated, or caused by diseases affecting small pulmonary muscular arterioles, for example, connective tissue disease, HIV, and congenital heart disease with left-right shunts. The process starts with damage to the endothelial cells lining the pulmonary arteries. These damaged endothelial cells release more chemicals that cause vasoconstriction and smooth muscle cells hypertrophy, while releasing less of those that cause vasodilation and inhibition of smooth muscle cells hypertrophy. As a result, this will cause lumen narrowing and increased pulmonary arterial pressure. Regardless of the cause, when there is pulmonary hypertension, it has important consequences on the lung and on the heart. It can cause pulmonary edema, and it affects the right ventricle and over time leads to hypertrophy. This actually helps in the beginning, but eventually the muscles in the right ventricle get so bulky that the oxygen demand exceeds the oxygen supply, which can lead to right-sided heart failure. When chronic lung disease causes right-sided heart failure, it's called cor pulmonale. Right-sided heart failure causes the blood gets backed up in the venous system, and this leads to elevated jugular venous pressure, hepatomegaly, and edema. Also, right-sided heart failure means that the left ventricle receives less blood, and to compensate for that, it has to pump harder and faster. All forms of pulmonary hypertension are associated with medial hypertrophy of the pulmonary muscular and elastic arteries, pulmonary arterial atherosclerosis, and right ventricular hypertrophy. The presence of many organizing or recanalized thrombi favors recurrent pulmonary emboli as the cause, and the coexistence of diffuse pulmonary fibrosis or severe emphysema and chronic bronchitis points to chronic hypoxia as the initiating event. One extreme in the spectrum of pathologic changes is the plexiform lesion, a tuft of capillary formations producing a network that spans the lumens of small arteries and may extend outside the vessel. It is most prominent in idiopathic and familial pulmonary hypertension. As the condition gets worse, people experience shortness of breath, fatigue and dizziness, fainting spells, edema, with bluish lips and skin. In the most advanced stages, it becomes difficult to do even minimal activity without having serious symptoms, including palpitations, difficulty breathing even while resting, and death from decompensated cor pulmonale. And now, my colleague will continue.
Pulmonary edema is the last topic. I'm Amina Moyasser, and I am pleased to present it to you. Pulmonary edema is abnormal buildup of fluid in the lungs interstitium and alveoli. This is the first thing that comes to your mind when anyone asks you about it. but it is more serious than just a fluid accumulation. To be more specific, acute pulmonary edema is a medical emergency that should be treated and immediately. Let's dive in deeply and find out more about the pulmonary edema. Pulmonary edema occurs when the alveoli fill up with excess fluid seeped out of the blood vessels in the lung instead of air. When fluid fills your lung, they cannot put oxygen to the bloodstream, and this deprives the rest of the body from oxygen. Thus, the body struggles to get enough oxygen and you start to have a shortness of breath. Sometimes it can be referred to as water in the lung when describing the condition to a patient. Staging of the pulmonary edema. Stage 1. All excess fluid can still be cleared by lymphatic drainage. Stage 2. The presence of the interstitial edema. And finally, stage 3, which is alveolar edema. The causes of the pulmonary edema. Pulmonary edema may be caused by a number of cardiogenic and non-cardiogenic causes and rarely a neurogenic causes. Starting from the cardiogenic causes because it's more common. Left-sided heart failure is on top of the list. But why? Why disease in the heart will cause a fluid accumulation in the lung? The left-sided heart failure, the ventricles becomes unhealthy and can't pump effectively, which means that blood starts to back up in the left atrium, pulmonary veins, and then the pulmonary capillaries sequentially. The extra blood in the pulmonary capillaries causes pulmonary hypertension, which is an increase in the hydrostatic pressure of the pulmonary blood vessels, and this pushes more fluid into the interstitial spaces of the lung, which leads to pulmonary edema. There are other cardiogenic causes, but they are not as important as the left-sided heart failure. For example, myocardial infarction, mitral aortic valve diseases, cardiomyopathies, or other disorders characterized by a cardiac dysfunction. Non-cardiogenic causes. In this condition, fluid may leak from the capillaries in your lungs' air sacs because the capillaries themselves becomes more leaky. Some causes, the acute respiratory distress syndrome, which is a serious disorder, occur when your lungs suddenly fill with the fluid and inflammatory white blood cells. Many conditions can cause ARDS, including severe injuries, systemic infections, pneumonia, and a severe bleeding. High altitude. Mountain climbers and people who travel to high-altitude locations run the risk of developing a high-altitude pulmonary edema. Drug reactions. Many drugs ranging from illegal drugs such as heroin, cocaine, to aspirin are known to cause an non-cardiogenic pulmonary edema by a central nervous system irritation. Hypothalamic stimulation leads to neurogenic control of adrenergic discharge, which results in increase of venous return and increase in left ventricular end-diastolic pressure, pneumonia, and many other reasons. Neurogenic pulmonary edema. Any sort of acute CNS injury may trigger neurogenic pulmonary edema. However, the three most common triggers of this syndrome are cranial trauma, subarachnoid hemorrhage, and epilepsy. Neurogenic pulmonary edema has also been reported in some other pathological situations, such as cervical medullary trauma, post-operative period of intracranial surgery, and a meningitis. The occurrence of the neurogenic pulmonary edema in a brain-injured patient is associated with a poor prognosis, as the mortality rate is very high. It is not only attributed to the pulmonary involvement, but also to primary brain injury. Histologically, we can see the following features. The slide on the left represents the normal lung microscopically. The alveolar wall are thin and delicate. The alveoli are well aerated and contain only occasional pulmonary macrophages, which is type 2 pneumocytes. At a high magnification, in a slide of the right, the alveoli in this lung are filled with a smooth to slightly follicular pink material characteristic of the pulmonary edema. Note also that the capillaries in the alveolar walls are congested with many red blood cells. Congestion and edema of the lung common in patients with heart failure and in areas of inflammation of the lung.
Hey there! Thanks for reaching up to this point. Here's a quick one-slide summary. Pulmonary vascular diseases are disorders affecting the blood flow through the pulmonary vasculature or fluid flow from the vasculature. They are a very diverse group of diseases, but we mainly focused on pulmonary embolism, pulmonary hypertension, and pulmonary edema. When it comes to pulmonary embolism, most of pulmonary emboli originate from the deep venous thrombosis of the legs. It can cause ventilation, perfusion mismatch, or inflammation, which will result in bronchoconstriction, hypoxia, hyperventilation, hypocapnia, and then respiratory alkalosis. Massive pulmonary emboli lead to sudden death as they occlude the passages of the large vessels. Pulmonary hypertension is increased blood pressure inside the pulmonary vasculature, as the mean pulmonary arterial pressure is equal or more than 25 millimeters of mercury at rest. It may be primary, as in pulmonary arterial hypertension, or it may be secondary, when there is a causative lung or heart disease, or other mechanisms. It may lead to pulmonary edema, right ventricle hypertrophy, which will cause right-sided heart failure, or cor pulmonale. Pulmonary edema is the abnormal buildup of fluid in the lungs, interstitium, and alveoli. It may be caused by a number of cardiogenic and non-cardiogenic causes. It is mostly due to increased load on the pulmonary capillaries following pulmonary hypertension, or could be from impaired pulmonary capillary wall, such as in acute respiratory distress syndrome or pneumonia. Its main clinical manifestation is dyspnea.